Hi guys, realized that I didn't get to the end of the PowerPoint for the Patellofemoral joint, and so I wanted to make sure that I got through all of the pathologies so that you at least had my lecture for the exam next week. And so what I'm going to do is go through the pathologies for the Patellofemoral joint, and then I will post both a study guide and provide descriptions for the study session that will be occurring next week for you guys. So what I mentioned in class is that patellofemoral pathologies really can be broken into 4 different groups or categories based on how the patient presents to you in the clinic. One of the first ways is that a patient comes in with patellofemoral pain that is as a result of a malalignment. The second way would be patellofemoral pain that is as a result of instability. Then you can also have a patient presenting to you with patellofemoral pain that doesn't have a malalignment. And one of the most common ways that individuals or patients develop patellofemoral pain is due to some type of traumatic condition. And we'll talk about each of these 4 categories independently. When we think about patient assessment and when a patient walks into our clinic with anterior knee pain, in my mind, it's a lot easier to assess them and the pathology once we understand which category the symptoms fall into. So that first group or category that a patient can fall into is patellofemoral pain with malalignment, as I mentioned. And this is traditionally known as patellofemoral pain syndrome, or PFPS as they call it in the research literature. And so what's the etiology of someone with patellofemoral pain syndrome? Traditionally speaking, PFPS is always or usually associated with some sort of malalignment and or faulty patellar tracking mechanism. And so you guys did the homework assignment for me. You know that the patella can either sit really high or really low, and we would call that alta or baja, that patella can slide either medially or laterally in the frontal plane, but also that patella can tilt, right? And so it can tilt laterally or medially, which means that facet on the side that it's tilted to will receive or have more contact with the femoral condyle, and as a result it will start to degenerate and wear away, and maybe the development of Chondromalacia Patella occurs. And so what is the pathology? The idea is that because there's this malalignment of the patella within the trochlear groove of the femur, that there's this increase in the compressive forces on the patella. And we've talked about, the patellofemoral joint reaction forces, and we've talked about which types of exercises and which motions at the knee would increase compressive forces and decrease them. But other reasons that the patella could become malaligned would be someone who has either genuvarum, which would be bow leg, genuvalgum, which would be knock-kneed, individuals who have increased or decreased Q angles. And so remember, we said normative Q value angles for females would be around 17 to 18, right? And then for males, it'd be around 12 to 13. And the anatomical reason for an increased Q angle in females is because we have a wider pelvis, right? And that's a beautiful thing because we can bear weight. One thing to also consider when we're assessing patients with patellofemoral pain syndrome is their foot posture, right? And if you have someone who is genuvalgum at the knee, more than likely secondarily to that, you would have someone who has a hyperpronated foot, right? And that in and of itself will place stressors or apply stressors across the tibial femoral joint and also cause the patella to become displaced as well. And so when we assess these patients with patellofemoral pain, we really have to do an overall global assessment. We can look at the knee, definitely. We can look at patellar arthrokinematics, but what we need to do is really truly look at the patient in a functional position, in a walking position, and also in a non-functional position, so in a seated position, just to ensure that arthrokinematics at the patellofemoral joint and tibiofemoral joint are also within normal limits. So what are the signs and symptoms of someone who presents to you with patellofemoral pain as a result of malalignment? They're probably all going to be very similar across most categories, with the exception of the traumatic category. So, pain when descending stairs. And remember, I said that the reason they have lots of pain with descending stairs is because it occurs around 15 to 30 degrees of knee flexion. And so as you're descending that stair, remember around 30 degrees is when the knee, at least the trochlea, makes most contact with the the patella makes the most contact with the trochlea, and then as a result there's this increase in compressive forces across the patellofemoral joint. And so patients tend to have more pain with descending stairs than they do with ascending stairs. You may get popping or clicking, more specifically if the patella is malaligned in the frontal plane, or if it's tilted as well. And so you might see some swelling in the peripatellar region. And then in some patients, it is also the case that the great toe, that they might have a lack of great toe extension, which secondarily what that means is if they don't have great toe extension, then they might not be good at propelling. They might not be able to get into dorsiflexion range of motion, and then that has implications for forces being transmitted up the kinetic chain. The next group of patients are patients with patellofemoral instability, and that instability could arise subtly, or it could arise from something more traumatic. And since we have a category of traumatic for patellofemoral pain, I'll leave that for later. But the subtle instability occurs as a result of laxity, specifically of the static restraints. And so remember, on the medial side, we said the major static restraint was the retinaculum, but also the medial patellofemoral ligament. And we said that that ligament provides about 60% of the restraint to preventing lateral translation of the patella. In other words, that medial patellofemoral ligament truly is going to prevent that patella from subluxing laterally. And if in some individuals that ligament is lax, they could be born that way, you could have subluxed your patella and stretched that ligament, then it creates an instability about the patellofemoral joint, and it also causes the patient pain in the anterior knee. And so how do we assess patellofemoral instability? It's pretty simple. We did it in class. We're going to take that patella and move it into the different planes of motion. We're going to look at sagittal plane movement, so anterior or superior inferior movement of the patella. We're going to look at frontal plane movement, so in other words, does it glide more medially or laterally? We're going to look at tilting of the patella as well. And so what are some predispositions to development of patellofemoral instability? There are a few. The most common type is having tight lateral restraints. So what that means is that the vastus lateralis might be tight, and or the distal IT band might be tight, and that those tight muscles on the lateral side then basically pull the patella laterally. And so if that patella sits in a lateral position, you are automatically basically causing the medial patellofemoral ligament along with its retinaculum to stretch. And so when you, let's say, do some type of treatment to release those lateral restraints, it's too late. That medial patellofemoral ligament is stretched, and as a result, there is patellofemoral instability at the knee. The other reason for patellofemoral instability is that patients have the shallow trochlea, and you guys can recall in class when Sam asked the question about the shallow trochlea. One of the biggest concerns with the shallow trochlea is that the patella doesn't sit well within the groove of the femur. So as a result, what you get is a more hypermobile patella, because you don't have the medial or lateral condyle to really resist major movement into either plane of motion, whether that be medial and or lateral. And so these individuals are more susceptible to subluxations, specifically lateral subluxations, which means that they're going to be more susceptible to instability, because if you sublux laterally, then you stretch the medial patellofemoral ligament. The next type of category that we'll talk about is, the traumatic category. And so one of the major mechanisms of injuries in the traumatic category would be a patellar dislocation. And the mechanism of injury would be, ideally would be about 15 to 20 degrees of knee flexion, and then a direct blow to the medial side, particularly the medial border of the patella, such that the blow is so forceful that it causes the patella to sublux laterally. And if we do that, then obviously the medial patellofemoral ligament becomes compromised, and if the force is great enough, the medial retinaculum could also become compromised as well. So we've kind of looked at this in class, I believe, but with the patellar dislocation, the biggest thing to consider is whether or not the tibial femoral joint is also involved, right? And so if the force was great enough to cause the patella to sublux or dislocate laterally, then it might also be the case that if that patient's foot was planted, you might have a tibial-femoral dislocation. So you have to be very careful when we're dealing with a patellar dislocation. And if we have cleared the tibial-femoral joint and there is no dislocation at the tibial-femoral joint, you know, honestly, the recommendation is that we would try to get the patient in some comfort. And you can do that by relocating the patella. And as we saw in the video in class, you can do that simply or subtly by having the patient basically extend their knee actively. And if they can't do it actively, then you can do it passively, but you might need 2 or 3 individuals to help you. As we saw in the video, one of the things that we saw is that the quadriceps muscles and the hamstring muscles are in a co-contraction, right? And so it's very difficult to get the knee into extension. So again, we really want these patients, if we can, we really want to reduce the dislocation. The big deal is that when we send them to the emergency room, if we don't reduce it, then they might be waiting for a few hours. And so in pain, yes, but eventually it will be reduced. And so the video that is playing now, we saw in class, is that we saw a group of physicians or an ER team basically working to relocate the patella. And, you know, after several tries, right, and the use of nitric oxide, then we could see that the patella was able to be reduced. And so we'll take a look at the video quickly as the physician is gliding that patella medially and extending the knee at the same time. And this is a painful process. What we see here is that the patient's toes are flexed, and so you really want to get that patient as calm as is possible. So some things that happen during a patellofemoral dislocation or a patellar dislocation. Number 1, you're probably going to get the tearing or rupturing of the medial patelloreticulum. You will definitely get some stretching and or rupturing of the medial patellofemoral ligament. And some graver concerns would be if, in fact, you do if the patella glides laterally enough that you might actually have like a chip fracture or a fracturing off of some of the lateral condyle, and as a result, you might get some hemarthrosis or bleeding into the joint line. And so again, you can reduce it with extension if you can overcome the co-contraction of the quads and the hamstring muscles. So what's the diagnosis? It's pretty obvious, right, for the most part, unless it's relocated itself when you run onto the field. But then, as we did in class, we can do a hypermobility and apprehension test. And with the apprehension test, we're going to glide that patella laterally while looking at the patient's face. And in patients who have completely dislocated, the big deal would be that you're looking at their face, because as you glide them laterally, they will become apprehensive about the fact that they're getting ready to dislocate their patella again. And then if you're concerned about maybe a fracturing of the lateral femoral condyle, if you're concerned about other trauma to the backside of the patella, then an X-ray and an MRI might also be necessary. So how do we treat these individuals? As mentioned in class, we're going to put them in a knee brace. And in this knee brace kind of has a lateral stabilizer built into it. And so what you're doing is you're providing stability to the lateral side of the knee so that the patella can't sublux into the lateral direction. And then what you're doing with these 2 straps is you're pulling that patella medially so that it just can't glide out of its slot. In some cases, if patients have completely just ruptured the medial patellofemoral ligament, they've completely damaged the medial retinaculum. In some cases, then surgical intervention is necessary. And so in surgical intervention, what they will do is repair or restore the medial patellofemoral ligament so that it can provide that static restraint that it's supposed to. In other cases where the dislocation wasn't way traumatic, it didn't really damage all of the medial structures, then you just put them into an extension brace for a few weeks, and then you're working on quad strength, hamstring strength, gastroc strength, and then you're just working on making sure that when they return to play, their patellofemoral joint arthrokinematics are restored, and you're also making sure that the tibial femoral arthrokinematics are restored, and correcting any other abnormalities that you might have seen in their overall assessment of the patient. So we go to the next category, which is patellofemoral pain without malalignment. And this is the patient who presents to you with some type of patellofemoral tendinopathy. So what we're saying is that this patient has some either patellar tendonitis and or a tendinosis, right? And tendonitis, if we can fix that, it's an inflammatory response. We can, depending on what the driving mechanism is, whether that be tight quads or some type of hamstring issue, or maybe it's the gastroc or it's abnormal foot positioning or foot posture, we can correct that. When it goes into a tendinosis where you actually have degeneration of the patellar tendon, then that's when we kind of become concerned, right? Because then that subsequently sets the patient up for potentially a patellar tendon rupture, which we'll talk about a little bit later. Other patellofemoral pathologies that cause pain at the joint without malalignment are the pathologies that plague the apophysis of the patient. And the two most common pathologies are Osgood-Schlatter's disease, which many of you are familiar with, and then Sindon-Larsen-Johansson's disease. And as I mentioned, this is something that I really hadn't heard of until I started teaching this course, but it's found at the quadriceps tendon attachment on the proximal pole of the patella, which is the opposite of Osgood-Schlatter's disease, where it's found at the tibial attachment to the patellar tendon. And so there are other pathologies that could arise without malalignment. That would be patellofemoral bursitis. And then last but not least would be the synovial plica, traditionally speaking on the medial side, and we'll talk about each of these independently. So Osgood-Schlatter's disease, there are several different causes. Traditionally speaking, we see this in the adolescent patient. And so what you would see is either you have increased quadriceps strength, so much so that it is placing a lot of tension on the most distal attachment of the patellar tendon at its distal attachment site on the tibial tuberosity, and as a result it either tugs on it so much that you have bony outgrowth or an exostosis that becomes very sensitive to touch, or the quadriceps contracts so much that it actually will cause an avulsion of the patellar tendon off of the tibial tuberosity. And so that's kind of what you see here in this x-ray image. So what do we do with these individuals? If they're adolescents and they don't have an avulsion fracture, we remove them from activity, and we really honestly try to work on both quadriceps and hamstring contractions, teaching the patient using biofeedback how to turn off the quads when necessary, or how to not hyper contract the quads. And then we work on controlling inflammation at the site of the attachment. And so that might be something like NSAIDs. It could be corticosteroid injection, maybe not directly into the tendon, but into the surrounding tissues. But last but not least, if we just can't get the patient out of pain and we've done rehab, then the next solution would be to surgically excise the tibial tuberosity and make it flatter, so that the patient is less sensitive to pain, and sometimes maybe even reattach that patellar tendon so that it's aligned in the right plane if necessary and if needed. This is a truly last resort treatment. Ideally, what we want to do is reduce the stresses being applied on the tibial tuberosity first, do this through rehab, and then control inflammation. And if these two conservative treatments don't work, then we go in and we do something more aggressive. We've talked about Sindon-Larsen-Johansson's disease, usually the result of a tight or shortened quadriceps muscle group. And these individuals are individuals who are going to compete in a lot of repetitive exercises that involve both jumping and running. And so the first group of student athletes that I would think of would be our track athletes, specifically our decathletes and heptathletes, who are doing a lot of not only running but jumping events. So they'll sometimes do the long jump, they'll do the pole vault, they'll do the shot put, which requires them to load the quadriceps and then unload it. And so those are the individuals that are most often plagued by this particular disease. Again, mostly seen in adolescent individuals, but of course it can be seen in the adult population as well, and most often seen in males. And so what do we do with these individuals? We have to remove them from sport, and then you just conservative treatment until the proximal portion of the patellar tendon has healed itself. So with bursitis, there had to be some type of traumatic force, anterior force being applied to the patellofemoral joint, or it could be as a result of repeated low intensity blows. And so by that, what I mean is that this patient spends a lot of time on their knees. And so let's say they're, I don't know, some type of maybe construction worker where they're required to be in a kneeled position while they're maybe working on putting things together. That repeated and constant pressure does cause the bursa to swell. And so what do we do with these individuals? We watched the video in class, right? And we saw that, man, these knees get pretty large. There's a lot of fluid on the knee. The negative to that is that when there's a lot of fluid on the knee, it reduces the amount of range of motion that we have at the knee, both in extension and in flexion. And so it could change the way that forces are distributed up the kinetic chain. And so number one, we remove the patient from activity, especially if that activity revolves repetitive landing or bumping of the anterior knee. Number two, we try to control inflammation. We try to do that by wrapping the knee and then padding the knee. And so what we do is we create almost like a donut pad over the patella, and so that when that patient lands, the pad absorbs the shock and not the anterior aspect of the knee. A last resort would be to aspirate the knee so that we could get some of the fluid out, so that patient would have an increase in range of motion. So I said that one of the reasons that a patient might present with anterior knee pain as a result of non-malalignment issue would be the synovial plica. The synovial plica, the one that's most often irritated, is the medial plica, and the onset honestly is insidious. I've seen it happen in 2 cross-country athletes. And so they literally, after just maybe running for several different miles over the week, came in complaining of a medial pain around the medial superior border of the patella. And the first time I'd seen it, I didn't know what it was. I honestly thought that maybe it could be the medial patellofemoral ligament. I did all of my laxity tests. That was within normal limits. So I thought maybe Chondromalacia Patella. I thought meniscus. I thought so many different things because the signs and symptoms are just all over the place. And it wasn't until we got the MRI that we actually saw that the plica was inflamed. And so the etiology is traditionally friction. The plica rubs over the femoral condyle and it gets inflamed. And when it becomes inflamed, it creates pain on either the medial or lateral side of the knee. Most often would be the superior patella plica, and then last but not least would be the medial plica as well. Those are the 2 most plagued plicas in the knee. So what are the signs and symptoms? It's clicking, popping, and anterior knee pain. When we think about a meniscus, what are some of the signs and symptoms? Some of the signs and symptoms are clicking and popping. And so a lot of the meniscal special tests will also be positive for a plica. In the lab, we'll talk about what special tests we could use to differentiate between a plica and a meniscal tear. So if in fact a patient has a synovial plica, what are the implications in the knee? Number one, loss of elasticity, and then alteration in the patellar gliding mechanism. And then patient could just complain of overall chronic disturbances in the knee if we don't care for it. Like I said, the differentials truly are meniscal pathology, patellar subluxation, and then a patellar maltracking issue, right? Which we're going to kind of rule out when we first have that patient come in and we assess the joint arthrokinematics, hopefully. Traumatic conditions. The number one traumatic condition plaguing the patellofemoral joint would be a patellar fracture. This occurs from usually a direct blow. However, it could also occur from the quadriceps contracting forcefully. And when they contract, what they do is pull the most superior piece of the patella away from the inferior piece. So if we had some degeneration going on, maybe chondromalacia patella, there's this forceful contraction of the quadriceps, it is possible that in fact you could create a patellar fracture. Most often though, the mechanism of injury is going to be honestly a direct blow to the patella. And so I said the etiology is direct blow. Like I said, you could also have a strong quadriceps contraction as well. And so let's take a look at this video here to see what the patient would present like. And so if you take a look at the basketball athlete, I mean, it is clear that his patella is fractured, right? So maybe replay one more time for those of you that didn't see that. And so with a patellofemoral fracture, remember the major role of the patella is to increase, right, the mechanical efficiency of the quadriceps muscles. And so it becomes important to repair the patella or to restore it so that the patellofemoral joint arthrokinematics are repaired. So what are the signs? Number one sign is a false joint. So going back to this video, the false joint is this right here, right? That looks like a joint, okay? And then number two would obviously be pain over the fracture site. But again, the number one sign would be the false joint. Patellar tendon ruptures, are very rare unless you're dealing with Olympic level weightlifting, or you're dealing with a patient who has had or has been suffering from a tendinosis and then maybe is doing something ballistic like the long jump or the triple jump, where they're expected to load that patellar tendon, and as a result, the patellar tendon, because either it has been inflamed and is degenerated, decides to give way, and it completely ruptures. And so what are the predisposing factors? Recurrent microtrauma to the anterior aspect of the knee. I would say the number one predisposing factor is tendon degeneration, or a patient who has a tendinosis. And then the other one is repeated cortisone injections. So let's say that we have a patient with patellar tendinitis. If we're trying to reduce inflammation in that area, the physician might go in and inject, and then maybe 2 or 3 weeks later, you want to do it again. So repeated cortisone injections actually cause weakening of the tendon. And so we have to be very careful with the number of cortisone injections that a patient gets in a season, because in fact, it can predispose them to patellar tendon rupture. This also goes for the Achilles tendon as well. So what are some signs of a patellar tendon rupture? Depending on where that rupture occurs, the patella could be alta or baja, tenderness, palpation, swelling, and then the condyles become a lot more palpable, right? Because if the tendon is completely ruptured through and through, it exposes the femoral condyle, specifically when we move that knee into flexion. And so what we can see here are exposure of the femoral condyles, because guess what is missing? Yeah, the patellar tendon, right? Imagine this is probably the ACL. And then if we look here, same thing. Well, what we should have somewhere in between here is the patellar tendon, but what we see are the femoral condyles readily exposed because we no longer have the patellar tendon covering it. So last but not least, I bring you to this. This is the evidence-based practice way to assess and to decide whether or not a patient needs to be referred for x-rays. And so this is going to be used to identify those that should be referred for an x-ray after an acute knee trauma. So if they are at 55 years of older, if they have tenderness to palpation over the fibular head, has palpable isolated tenderness on the patella, so the most anterior portion, they can't flex their knee to 90 degrees, and if they're unable to bear weight for 4 steps immediately following the trauma, then we need to refer them to rule out some type of fracture to the knee. Doesn't this remind you of the Ottawa ankle rules? The answer is yes. So again, if you see an acute injury to the knee where the patient takes a blow and you're concerned about a fracture, you should use the Ottawa knee rules to help you to decide whether or not you need to refer. The patient's older than 5, if they are 55, if they demonstrate tenderness to palpation on the fibular head, if they have tenderness to palpation on the anterior aspect of the patella, they can't flex their knee to 90 degrees, and if they can't bear weight for more than 4 steps, then we need to refer. This is the end of the PowerPoint presentation. As always, if you have any questions, please let me know. Otherwise, I look forward to seeing you in lab tomorrow and then testing all of next week.